Well, happy Wednesday, everybody. Welcome. Thank you for taking time out of your day to join us for our webinar Wednesdays here at Zomedica. We are very excited to be presenting our topic today on the Hemoperitoneum splenic mass. It is being presented by Dr. Shadi Irifej. And Dr. Shadi, I'm going to call him Dr. Shadi for short, graduated from the State University of New York at Binghamton, where he received his Bachelor of Science degree in biology, 2001, magna cum laude. He then attended Cornell University, where he received his Doctor of Veterinary Medicine degree in 2006. After completing his studies at Cornell, he participated in an intense one-year small animal medicine and surgery rotating internship at Angel Animal Medical Center in Boston, where followed by 2 years of rigorous one-year animal surgical internships at Long Island Veterinary Specialist in Plainview, New York. Dr. Irifej achieved his board certification in small animal surgery by completing a 3-year small animal surgery residency at LIVS in 2012, and subsequently became a diplomat for the American College of Veterinary Surgeons. After operating for almost 10 years at LIVS, he moved to Las Vegas, Nevada in 2016. And in Las Vegas, he became a staff surgeon at Las Vegas Veterinary Specialty Center. In 2017, he began flying across the United States, performing surgeries at a number of emergency and specialty hospitals in need of surgical assistance. This was followed by a chief of surgery position at United Veterinary Specialty and Emergency in Silicon Valley, California, and managing their 3 locations. And his team successfully cared for dogs and cats in the Campbell, Mountain View, and San Jose areas. And in 2018, Dr. Irifej joined True Care for Pets in the Los Angeles area as chief of specialty, where he was instrumental in morphing the after-hours and weekend emergency hospital to a successful 24/7 emergency and multi-specialty veterinary hospital. In 2020, he changed gears in his already illustrious career, finding a novel and state-of-the-art means of reaching concerned pet owners and their ill pets worldwide: Vet Triage. Dr. Irifej currently serves as their chief medical officer, and he's been published in scientific and medical journals and enjoys lecturing to a variety of audiences. He's known for being a positive force and energetic force, both professionally and personally. So without further ado, please join me as we're very excited to welcome Dr. Shadi Irifej.
Thank you so much. Thank you to Zomedica for setting this up, and thank you for everybody who's listening and watching this. I really appreciate it. And so our focus today is going to be on hemoperitoneum, specifically as a cause of, as a sequela of splenic masses. And you've already heard my background. For those of you who don't know me, I currently operate Vet Triage full time, but spend a good amount of time throughout the year giving talks, giving surgical talks. So this will be our outline. If you haven't received the proceedings yet, when you do receive the proceedings, those notes go into a lot of detail to the point where it's almost academic, but those proceedings will have way more information than we'll talk about here. The goal here with this discussion is to make this as practical and clinical as possible, so you can actually utilize this in your practice. Even if you don't perform splenectomies, it's still that initial client interaction, diagnostic workup is paramount. But those proceedings have a lot more notes, a lot more detail than we'll go into here today. So this is our outline. We'll start with some anatomy and function of the spleen. We'll talk about the incidence of splenic masses, the pathogenesis of such masses, what can you expect as far as signaling, clinical signs, what sort of diagnostics are you going to perform, how to stabilize the patients, treatment options, and of course focusing on surgery. After surgery, we've got postoperative outcomes, complications, predictive factors, prognostic factors, some final key points, and any questions that folks may have. In brief, the anatomy of the spleen is well known to a lot of us veterinarians. The picture there on the left with the dog is a little bit misleading. If you can see, the spleen is sandwiched between the stomach and the kidney there, which is not entirely true. The spleen actually is quite mobile and can vary in its shape. This is important when you're collecting radiographs to evaluate the spleen. It will silhouette with the liver and surrounding soft tissues, and because it can vary in size and positioning, it can cause some confusion with veterinarians in terms of how to interpret or overinterpret the radiographs. Obviously, abdominal ultrasound gives you a lot more detail in that regard, but just so we're all aware, the spleen can change in shape, size, and location quite often. And then on the right side, we have a gross depiction of the spleen as well as its vascular supply. So the short gastrix, the left gastrocaploic, the splenic, and then those that feed from to and from the omentum. And so this is the typical vascular supply of the spleen. This is of course imperative because if the spleen gets involved in a gastric dilatation and volvulus, for example, the short gastric arteries and veins are typically ruptured, or splenic torsion, the vascular supply matters. Most importantly to us, most commonly, is going to be splenectomy. The goal here is to ligate the pedicles, and so you need to know the anatomy to some degree. In a situation where the spleen becomes congested because of a GDV or splenic torsion, of course, or even aggressive cancers, the vasculature may not be as straightforward as these pictures depict, but as far as knowing the basic anatomy of the spleen, this is vital. And another drawing there regarding the vascular supply of the spleen and all its different branches. And the other point of this too is, if you notice the proximity of the stomach and the pancreas to the spleen, you don't want to compromise the pancreas and stomach's blood supply when you're removing the spleen. And so the knowledge of this anatomy is also vital for that reason. I will say, because when you are typically removing the spleen, you're not necessarily going for margins. You're trying to remove the entire spleen, and that's that. The safest thing to do as a surgeon is to stay alongside the spleen, and you're not even worried about compromising pancreatic or gastric blood flow, because you can stay right alongside the vascular side of the spleen and ligate all those pedicles. Going into more anatomy regarding the spleen, I want to remind folks that it is a very complex organ that functions as an immune system, not just blood supply and or hemostatic. And so these are just the depictions of the important structures of the spleen on a microscopic level. The spleen is a very important immune organ, and it is responsible for white blood cells, producing antibodies, and immunoregulation, immunosurveillance, all that good stuff. Very important for the spleen. You can see the picture of the red blood cell, which is what we typically think of splenic function as a source of blood supply. In animals that are, for example, suddenly anemic, splenic contraction helps contribute to the red blood cell mass of that patient. But it also has other functions regarding the immune system. And then that cytology picture there with the big arrow, that's a platelet. And so don't forget, of course, the spleen does provide a reservoir for platelets also. So the spleen is a very important organ in multiple facets, not just as a blood storage organ. Now let's go into the incidence of splenic lesions, and specifically focusing on cancer, but of course, cancer is not the only thing that can affect the spleen. In terms of some statistics here, between 0.3 to 2% of all neoplasia in dogs over 8 years of age comes from the spleen. So it's quite a common one in clinical practice. Especially as a specialist, we will see a lot of splenic masses referred over to us. The splenic neoplasia makes up 5% of all non-skin primary malignant cancers in large breed dogs. In cases of splenic lesions, neoplasia is found somewhere between 48 and 66% of cases, unclassified in 0.4%, not neoplastic in 34 to 55% of cases. Overall, if you're speaking to a pet owner, you can quote them these numbers. The overall malignancy incidence of splenic cancer is about 76%, benign 24%. Keep in mind, I'm going to stress this as I do stress it in the proceedings. These numbers are highly variable. As you can see, there's wide ranges, and that's because every study is different in terms of how they're monitoring, how they're keeping track, collecting their data for splenic lesions in dogs. It causes a lot of confusion and intense interpretation of these papers. So I tried my best to consolidate these papers into numbers you can actually use. So in general, 3/4 of dogs with a splenic mass will have cancer, and about 25%, 1/4 of dogs will have benign disease. The overall incidence of splenic neoplasia, 33 to 66%, 80% being malignant, benign 10%, And again, you can already see there's variation in these percentages from the last slide because it's tough to try and consolidate these. But in general, 75 to 80% malignancy rate, which is very high, of course. Of the malignancy, between 50 and 90% will be hemangiosarcoma. No surprise there. Overall, hemangiosarcoma is found in 65 to 88% of affected dogs. Splenic hemangiosarcoma associated with a hemoperitoneum, 76% of cases. Splenic hematoma with the hemoperitoneum, 29% of cases. With hemangiosarcoma, in 75% of such cases, the hemangiosarcoma lesion is a source of the hemorrhage with hemoabdomen cases. Just as a side note, the term hemoabdomen is what we typically will use, although technically speaking, if you're respecting the anatomy, hemoperitoneum is the appropriate word. It's blood-filled peritoneal cavity as opposed to the abdominal cavity, which would be including the peritoneal layers. But it's semantics. A lot of the internists will stick with hemoperitoneum when they're performing ultrasounds and writing those ultrasound reports for the surgeon. I did want to make sure we are aware there were other cancers. There's a long list of other malignancies that can affect the spleen. So these are typically seen in 22 to 43% of cases, but hemangiosarcoma, of course, is the most commonly seen cancer. So hemangiosarcoma will be our primary focus, and it's a malignancy of vascular endothelial origin that results in widespread metastatic disease and a poor survival in dogs. There's a ton of primary sites. Of course, the spleen is the most common primary site, and there's a ton of metastatic sites. Liver is most common, followed by omentum, followed by mesentery in terms of incidence. And those of us who have performed surgery and worked up these cases for splenic hemangiosarcoma, we're no stranger to that. If you see there with the metastatic hemangiosarcoma, we have heart as the fourth. It's about 9% incidence of cardiac involvement, and so the question of whether or not a cardiac workup is indicated in these cases, it kind of depends. It is not that high of a rate, but of course it's devastating if you are performing a splenectomy in a dog that has also cardiac mets, because a cardiac mass may not show up on your standard 3-view thoracic radiographs for a metastatic screening. And ideally an echocardiogram is the way to go, but most facilities will not have access to an echocardiogram, especially in the middle of the night with a critical hemoabdomen and you're trying to rush into surgery. It's just not a luxury that a lot of us have. So thankfully it's only 9%, but it's not 0%, so we have to be aware of it. It really, basically what I'm saying is a discussion with the pet owner so they understand this is essential. Once the splenic mass ruptures, this is just a small list of the sequelae that causes these patients to be more critical. Decreased oxygen transport is affected due to a decreased circulatory red blood cell volume. You have an exercise-induced systemic oxidative stress, which increases circulating hematopoietic stem and progenitor cell production, restrictive lung disease, anemia, DIC. DIC is actually seen in 12% of solid malignant tumors and is an increased rate with hemangiosarcoma. So these are just some of the many reasons why these patients show up critical to the hospital. Obviously, this goes a bit beyond the scope of this talk, but just be aware that hindrance to oxygen transport is a massive reason why these pets are struggling preoperatively. When you look at trying to stage this disease based on the World Health Organization's parameters, stage 1, 2, and 3 are what we typically will delineate. Most of us in practice don't really gauge it this way, but the reason why these stages matter is because stage is correlated with prognosis long term. Stage 1, localized disease with only the primary tumor. Stage 2, there's primary tumor with lymph node involvement or it's ruptured, so hemoabdomen, hemoperitoneum. Stage 3, you've got the splenic rupture or lymph node involvement plus metastatic disease. On the right there, you can see there's a table for the TNM criteria for these dogs, and so you can read that as well. That's another way of describing the different stages for hemangiosarcoma. This TNM categorization is used with a lot of cancers, not just hemangiosarcoma. This is not unique to that. So more importantly, it's the staging, and that's clinically how you can interpret what stage that patient is in. Let's move on to signalment, and those of us who are watching who are veterinarians are well aware of this. Although there's a wide age range of dogs that are affected with splenic masses, the mean age is 10 years. So I tell pet owners when they ask me about anesthesia in an older dog with this condition is what's the risk involved? To me, the risk is equal across the board in terms of age as it relates to anesthetic risk, because this is typically not a young dog disease, right? This is typically a middle-aged to older dog disease, and so they're all the same playing field. They're all at risk of anesthesia. It's just a matter of individual biology, how critical the patient is, comorbidities, what your blood work is showing, etc. So they're all going to be older dogs. Golden Retrievers, German Shepherds, of course, are the main culprits here, but any large breed, extra large breed dog can be affected by this, and there is a slight predisposition towards males as opposed to females. Clinical signs, we are all familiar with this as well. I have had dogs that when you investigate further into their history, the pet owner will go into a more kind of long-term chronicity of clinical signs. And my belief is that some of these dogs that are developing splenic masses, benign or malignant, doesn't matter. If they occasionally have a bleed, the pet is clinical, and then the body stops the bleed, the pet is good again. And so if you investigate with these pet owners more thoroughly, going into the history beyond just the acute or periacute, you'll find that there was actually some fluctuating symptoms, or clinical signs rather, for that dog months preceding the presentation of a hemoabdomen. But in general, clinical signs are weakness, lethargy, abdominal distension, tachycardia, tachypnea, pale mucous membranes, weight loss, collapse, and those pictures are pretty classic for a dog showing up with a hemoperitoneum. Keep in mind, again, our discussion here is focusing on splenic masses. We're not talking about other causes of visceral hemoperitoneum like an adrenal gland tumor that ruptured or a liver mass that's ruptured. And we're not talking about things like coagulopathies from everything from hemophilia to rodenticide toxicity or trauma. We're focusing purely on splenic masses. So this discussion is focused on that. But I don't want the audience to think that only splenic masses cause hemoperitoneum. That's not the case. There's many differentials, but a common one is splenic masses. On your diagnostics for a CBC, typically what you're going to find is a low platelet count, high white blood cell count, and the high white blood cell count is characterized by neutrophilia, and then of course anemia as well. The anemia is typically non-regenerative. You may see nucleated red blood cells. You may see schistocytes on the blood panels, but these are just some of the things you're going to find here. You may think, well, if the dog is thrombocytopenic, do you want to take them to surgery? Well, the answer is yes, because if you think about the broad causes of thrombocytopenia, this is likely, in this case, going to be a loss of platelets as opposed to a bone marrow issue or an immune-mediated thrombocytopenia issue or a sequestration issue, although it could be sequestration into the spleen, but most often it's going to be the fourth reason, which is going to be loss of platelets. And so these dogs are typically, although they can be coagulopathic, the thrombocytopenia isn't necessarily a cause of their coagulopathy, at least to the point where you have to postpone surgery or not perform surgery on them. But again, you can have coagulopathic dogs, and so you're looking for other reasons why they might be other signs of coagulopathy, not just low platelets. And at the end of the day, you don't really have a choice. If there's life-threatening internal bleeding, then you need to take action if you're going to try and save that pet's life. Radiographs, don't forget our MET checks. 3-view thoracic radiographs are imperative for the workup on these dogs. You're looking for any changes to the cardiac silhouette. Let's say, for example, if you have a pericardial effusion, a pericardial tamponade from a metastatic lesion to the heart, you're looking for that. Effusion could be either cancerous, malignant effusion, or it could be a general inflammatory response, or it could be from a coagulopathy as well. The picture, the radiograph on the bottom of the screen with the yellow arrows is supposed to depict pleural fissure lines. So the pleura is filled with fluid, and it's in between the lungs, of course, and so those are the lines you're looking for pleural effusion. You may or may not see lymphadenopathy, either sternal or pericardial lymphadenopathy, and then of course you're looking for mets to the lungs, to the spine, all the organs that you can see there on your thoracic radiographs. Abdominal radiographs, very useful. There's the radiograph there with a homogeneously enlarged spleen. Could that be liver? Sure, it could be. It could be kidney, adrenal gland, pancreas, small intestine, lymph node. There's a variety of organs in that location of the abdomen. But typically speaking, if you're seeing a soft tissue mass effect on the cranioventral portion of the abdomen, it's most likely going to be spleen. But keep in mind there are other masses that could be in that location, or other organs that could be infiltrated by a mass in that location. And then ultrasound can vary in what it looks like. Typically, a targeted lesion is what the ultrasonographer is looking for classic hemangiosarcoma. But for example, splenic lymphoma can have that more mottled type appearance to it, for example. So the ultrasound is imperative not just for characterizing the spleen and the splenic mass or masses, but you're also looking for metastatic disease, especially in liver, omentum, mesentery. Fine needle aspiration and cytology is a okay way of trying to diagnose splenic masses. I'm sure internal medicine doctors would disagree. I often will have, if FNA is performed before I get a hold of the case, typically it's coming back as extramedullary hematopoiesis or peripheral blood, and I don't really know if I can believe that. And of course, there's a risk of iatrogenic hemoabdomen from fine needle aspiration, but you can consider that as a minimally invasive way of trying to diagnose this. Otherwise, if you have the luxury of CT scan and MRI available to you, and the patient is a stable splenic mass, not an active hemoabdomen, then sure, you can characterize the spleen further using those diagnostics. But by far, we're talking about radiographs here, and if you have available abdominal ultrasound. Exploratory laparotomy is the way to go, obviously for confirming the diagnosis, but also for treating the problem. And then histopathology confirms it as well. Another talking point here that I want to stress is with histopathology, the liver needs to be biopsied. To me, it doesn't matter if the liver looks normal on radiographs and ultrasound and grossly in surgery. Liver biopsy is mandatory, at least one lobe. If you see a lesion on the liver and you can safely access it without causing a problem, certainly you want to biopsy the lesion. But if the liver looks normal on gross inspection at the time of ciliotomy, collect a biopsy. It's such a high metastatic rate, and its number one location is liver. You're obligated to biopsy the liver. The image up top there with the red arrow is showing a vertebral mass is compressing on the spinal cord. Obviously, there could be other causes for vertebral masses, but hemangiosarcoma does just to remind folks that it does spread there. I have had cases that have spread to the vertebral canal. But most of us are not performing 3D imaging, right? Advanced imaging for these. I'm just making sure that you have kind of a general overview of this. Here's a CAT scan on slide A or picture A there. The arrows are showing the spleen. It's enlarged. It's got a cavitated mass associated with it. And then slide B is suggesting that there's a metastatic lesion in the lung there on CT scan. Stabilization, of course, is a whole other topic all on its own, so we won't go into crazy detail. Any questions you have, I'm happy to try and tackle them as a surgeon. Usually the surgeons are responsible for the stabilizing of the patient, but if you're fortunate enough to have an emergency critical care specialist on hand, great. Otherwise, your typical measures of fluid resuscitation and trying to stabilize them hemodynamically. You want to have 2 large bore catheters in these dogs, ideally, and then the access to blood products, whether it's whole blood, packed red blood cells, whatever it is you have access to, depending on your preference as a clinician and what the patient needs, but some sort of way to manage their cardiovascular collapse. Otherwise, other colloids like hetastarch can be used as well, but keeping in mind, of course, that doesn't fix the anemia problem. That's purely a vascular expansion. The picture there at the bottom with the glove is trocherization of the stomach. And yes, you can do that, of course. I find that with how big the stomach gets, that this procedure to try and therapeutically release the pressure from the distended abdomen, which is compressing the vena cava and the liver, all that stuff. I don't know how useful it is, but there are definitely, and I'm sure folks who are listening and watching this, they've stabilized patients, or it's helped them stabilize patients by trocherizing them. I've never done it myself, because by the time I'm involved with the case, my goal is to get them under anesthesia, pass an orogastric tube on the way to the operating room, and then from there performing the surgery. But it is a viable option, That can save lives, of course, especially if that's your only chance. The patient declining despite your best efforts, and you're still waiting for the surgeon to arrive, or the client is still trying to make a decision, and you want to maximize the stability of this patient. It's certainly a viable option. These are all different types of surgical procedures associated with the spleen. We're going to focus, of course, on splenectomy, but don't forget liver biopsying these patients. Prophylactic gastropexy is interesting because the same dogs that suffer from a splenic mass are the same ones that suffer from GDV. And GDV is typically a middle-aged to older dog disease. And whether or not you perform a gastropexy at the time of surgery, I don't know. It involves communicating with the pet owner. The way I usually will phrase it is typically if the patient's stability warrants me being able to gastropexy them, I will do it. Otherwise, a patient's life comes first and not preventing a GDV later on, especially when you talk about, maybe a month to 3 months survival with hemangiosarcoma. Whether the chances they'll have a GDV in that time frame, we don't really know, but there are studies that suggest that the gastric mobility in these dogs after removing a spleen is higher, and therefore there's a risk of GDV post-operatively. So you can make both arguments. My discussion with the pet owner is if the patient is stable enough, I'll perform it. If not, we're going to abandon that ship and just focus on the problem at hand. Other biopsies I put in there because you'll have a dog that comes in for a splenic mass, hemoperitoneum, needs an emergency surgery, and the owner is like, oh, by the way, she has a mammary gland tumor. It's been there forever. Can you remove it? She's got a lipoma. Can you remove it while you're doing it? Can you perform a dental while you're doing it? And it's the same conversation with the gastropexy. It's going to be a low priority. If I have the luxury of doing it, sure, I'll do it. Otherwise, the patient's life comes first. But just letting you know, you'll be faced with those decisions. If you have a dog that's got bladder stones at the time of the splenic mass diagnosis and needs emergency surgery, do you perform a cystotomy at the same time? Depends. You have to talk to the pet owner about pros and cons of that and what you feel comfortable as a surgeon. And then, of course, other comorbidities. These are older dogs, right? So they have arthritis, they have diabetes, hypothyroidism. There's other conditions that they may be suffering from that impacts the case itself and the owner's decision making. On the bottom right there is a drawing of performing a liver biopsy. There are a number of ways of performing a liver biopsy, and whatever technique you want to use is fine with me. This is showing at the top there is repairing like a splenic laceration, let's say. So I don't think I've ever even performed one. It's just not a common thing. I suppose the most common reason for doing this is if you're entering the abdomen and your scalpel blade accidentally hits the spleen, then that's a reason for that. Otherwise, to see an isolated splenic laceration from like external trauma, hit by car or whatever, I haven't seen it. And then the bottom picture there, the bottom drawing, shows a partial splenectomy, which brings me to my next talking point. That is, never, ever, ever, ever perform a partial splenectomy in dogs unless you're absolutely certain the reason why you're removing a part of the spleen is because it was known to be traumatized by, let's say, for example, an intra-abdominal herniation, and the spleen became entrapped, and that part of the spleen lost its vascular supply, then maybe you can argue that a partial splenectomy is the way to go. But essentially, because at least 3/4 of dogs with splenic lesions are going to have malignancy, it behooves you ethically to remove the entire spleen. Dogs don't need their entire spleen or even a portion of their spleen for longevity, whereas in people, we become severely immunocompromised without a spleen, and so they will try to salvage a portion of your spleen as a person, even with cancer, but the incidence of malignancy in people is lower than it is in dogs. And so never, ever, ever, ever will you perform a partial splenectomy in general, especially with splenic mass. And in the rare case that you have splenic trauma, you can make the argument for that. But I have never performed a partial splenectomy. It's always been a total splenectomy that I've performed. But keep that in mind, because it's tempting, right? Because you have an isolated small splenic mass at the tail end of the spleen, easily accessible. I can just knock that thing out and save the rest of the spleen. Do not do it. Remove the entire spleen and submit the entire spleen for biopsy. These are just different ways of performing any vascular surgery, splenectomy or otherwise, depending on what you have access to. You can use the ligature device, which is the very top middle gun there, is my favorite. There's the one on the left is a smaller size up top, like top row there. But I love ligature. It's fantastic. It's like Pac-Man. It just goes right through the vascular supply. There are sometimes vessels that are too big for the ligature, in which case you want to ligate with sutures. Or in general, if you just want to make sure that you have the most secure, the main splenic artery and vein, you want to use suture for that. Otherwise, various techniques can be used depending on your skill set and your experience, what you have access to. So, outcome with hemangiosarcoma. The stage 1 dogs, you're looking at about 151-day mean survival time. Stage 2, 107. Stage 3, 73. And you can see stage 3, there's a range there. So stage matters in terms of post-operative, long-term survival in these dogs. The stage matters. Stage 1 plus 2 dogs. This is just cohorts. This is not a dog that has both stages. 50 to 75% within 86 days survival. 1 year survival 6%. I'm surprised that 1 year survival is even that high, but I've had dogs that were supposedly diagnosed with splenic hemangiosarcoma that have come to me years later, which then you kind of question the initial diagnosis because it can be a bit tricky to diagnose this. Benign disease survival, you're looking at 650 days with a 1 year survival of 85%, 3 year 45%, 6 year 30%. Those numbers make sense. Malignancy in general, 85-day survival, 1 year 20%, 3 year 10%. That's malignancy of any kind, not just hemangiosarcoma. The hemangiosarcoma cases have a 30% of cases that survive 2 months, 7% 1 year. Hemangiosarcoma with surgery alone, median of 86 days, versus chemotherapy that can pretty much double it. And so, whether or not that's worth it to that pet owner depends. Depends on that pet owner. They have the finances, where they at emotionally with this. They want to put their dogs through chemo. It warrants at least an oncology consultation and talk about pros and cons of chemotherapy. But chemotherapy can potentially double their survival time. Hematoma survival, 85% 2 months, 65% 1 year. Overall survival 338 days. I don't want to give the impression that splenic hematoma dogs die from the hematoma later on. They probably are dying from other diseases that they have as older dogs, or just geriatric, just old age. But these are the numbers that we have. Postoperative complications. So I have a list of these in your notes. I want to touch on the VPCs, ventricular premature contractions there. And that's probably one of the more common ones that I'll see postoperatively. You can see a pre-op, intra-op, or post-op to varying degrees, all the way to in the bottom there, VTAC, ventricular tachycardia. And there are ways to medically manage this. I'm happy to talk about more specifics if the audience is interested in that. My familiarity with it, with treating arrhythmias, is lidocaine and procainamide. That's where I usually go. But if you have the opportunity for an internal medicine specialist in your facility or an emergency critical care specialist, it's always good to run it by them and see what they think in terms of interpreting the ECG and how to manage any arrhythmias. But of course, with such a severe diffuse cardiovascular disease like hemoabdomen, hemoperitoneum, there's a variety of different sequelae to it for these dogs. So acid base and electrolyte imbalances, hypoxemia or ischemia to the heart due to poor venous return and being in shock. The large mass size, as we mentioned earlier, obstructs the caudal vena cava, decreases venous return. Microembolic disease from being coagulopathic. Perhaps there are cardiac depressant factors from ischemia to nearby organs or from the hypovolemia itself. And then how much of these complications are due to us as doctors manipulating the spleen. I very careful, not just when I'm manipulating the spleen to not cause further splenic rupture, because these tissues can be friable, but also how much manipulation can I get away with to remove the spleen, but also not necessarily test the body and release depressant factors or cause further debilitation to the heart, causing arrhythmias. Splenic torsion, I only mention it here because I've seen splenic torsion, and whether or not the splenic torsion caused the hemoabdomen or if it was a primary or was a secondary condition due to a large spleen that was more mobile and then a blood-filled cavity, I don't know. But my point with the splenic torsion is you're not going to untors it. Do not untors it. The second you untors the spleen, it's going to release all of these radicals oxidative radicals and cause arrhythmia and diffuse microembolic disease. It's horrific. And so splenic torsion, you're going to remove the spleen at the base of the pedicle where it's torn, trying to keep in mind of the blood supply to nearby viscera. This is where it matters. They need to make sure that the pancreas and stomach are going to be okay, but do not untors the spleen. This is very, very, very rare to see splenic torsion in general, but just in case, I don't want folks to detours the spleen. Predictive factors. These are predictive factors that will dictate whether or not the dog has hemangiosarcoma. So typically, hypoproteinemia, thrombocytopenia, having abnormal red blood cell morphology, and having hemoperitoneum are associated with a higher risk of being diagnosed with hemangiosarcoma. The mean mass to splenic volume ratio is higher in benign diseases versus other malignancies, and especially compared to hemangiosarcoma. You can see the numbers there. Benign splenic masses tend to have a higher mean splenic weight as a percentage of body weight versus hemangiosarcoma. These are not going to be, of course, foolproof, right? But these are things to help a client decide where they want to go with this case. Prognostic factors, interestingly enough, older age may increase survival. Another prognostic factor is how bad the anemia is. That'll also affect mortality. The number of lesions present, if they have more than one. No dogs are alive by 1 year of age versus they have one lesion. 16% are alive at 1 year. The stage of the dog we mentioned already. Having high neutrophil count and low platelets is associated with DIC. And then, of course, anything that's affecting the respiratory tract, like ARDS or pulmonary thromboembolism, increases death substantially. These are all factors that influence prognosis. Having bicavitary effusion increases the death rate. Having tachycardia usually means you need a blood transfusion, which then usually means there's a higher chance of dying from the condition. Hyperlactatemia preoperatively is a negative prognostic factor. Having VPCs, splenic torsion are negative prognostic factors. The spleen being a source of bleeding is a positive factor, and that's probably because that's treatable. You can remove the spleen. Whereas if you have a hepatic mass that's hemorrhaging, you may not always be able to access that safely and remove it safely. Then we will finish up here by talking about monitoring, because I believe that the success of surgery is dependent on the patient's biology and their circumstances, comorbidities, how critical they are, how great your team is, your diagnostic tools, but then monitoring. Monitoring is massive. And the most common confusion that I see with general practitioners who want to perform splenectomy is how do they monitor postoperatively? And it's usually a lot less than what I would consider as a surgeon to be ideal. Monitoring, of course, can be manual, so using a human being. There's some subjectivity to that, whether you're looking at something, hearing something, feeling something. It's a bit less objective than using devices. And if you can have a device that will monitor a patient more remotely, meaning minimize stress to the patient, minimizing the workload of your team, that's even better. And so I'm very happy to talk about VetGuardian, which is a contactless device to help monitor critical patients. This can be used for patients that are stable, elective splenectomies as well, but it especially shines when you're talking about those patients that are quite critical. And if you're talking about an older pet who's really debilitated from being in shock and then undergoing surgery, anesthesia, having a tough postoperative recovery, this is great. Minimally manipulating the patient and trying to maximize the diagnostic value. So vital measurements are going to be attained with this diagnostic tool: body temperature, pulse rate, respiratory rate, movement of the patient, and then using Doppler radar and thermal imagery, it can try and detect warning signs of impending cardiovascular and pulmonary issues with these patients. It's continuous. So one of the biggest downfalls to spot checking with electrocardiogram and ECG is that you could miss a heart arrhythmia. If you're performing an ECG for 30 seconds, a minute, maybe 5 minutes, maybe, you're still missing hours and hours and hours between your next ECG measurement, whereas continuous is really mandatory to catch any and all arrhythmias that you can. And then of course the device will send alerts out as well, and it stores all the data. So it's very cool. And that's the top right is a picture not only of a dog that's being monitored with VetGuardian, but at the very top you can see there are multiple patients being monitored simultaneously using the device. And so you can have a nice query of patients that are being monitored. So it benefits not just your staff from having to do less work in terms of attaching a blood pressure machine or an ECG machine, checking a pulse ox, and then of course the pet benefits by less interaction with the staff. So they need to rest from the procedure. Plus, if you have a patient that's being affected by cardiac arrhythmias, they are more likely, even if you take them for a basic walk, prone to collapsing. You're stressing out the cardiovascular system, and the problem with VPCs and other arrhythmias is that they have inadequate filling of the heart, inadequate perfusion, and so they just can't handle that. So if you can monitor them with less manipulation, it's better for the patient. The clients, of course, benefit from this. The practice benefits from it. Telediagnostics really are the future. Having created vet triage and been in the telehealth space for almost 5 years now, telediagnostics are the way to go. And we all know this for those of us who manage diabetics, for example. These blood sugar levels are monitored at home. And telediagnostics like VetGuardian it's the future. It's already here. And the potential for this is going to be is massive. So yeah, this is just a depiction of the cool technology that this device uses. Here's a close-up of the diagnostics, the diagnostic results of it, and it's showing on different devices as well. Pretty cool. So so I can't speak highly enough. And not just for hemoabdomens, but for other diseases as well that you're worried about manipulating the patient or patient anxiety. Respiratory cases are great for this. If you can monitor the patient without continuously opening the oxygen cage to assess them, it's very beneficial. So key points I want to make here to wrap up, and then any questions folks have. Keep in mind your proceedings are based on splenic mass literature, which can be very difficult to interpret. I try my best to consolidate things so you can at least have something to use for client communication clinically. Client communication is massive for this disease because of comorbidities, because of adjunctive procedures you may want to perform, like gastropexy or cystotomy or whatever. You need to tell the clients, we got to prioritize these procedures. And they have to also be aware of the risk of cancer with these dogs and the risk of postoperative complications. So, and all this has to be done in conjunction with what's their financial capabilities and what's the viewpoint on quality of life. It's part of spectrum of care. Talk to the client about where they're at, emotionally, financially, all the things before they commit to a procedure like this. Don't forget, always submit the spleen for histopathology. It doesn't matter to me how benign it looks grossly or on ultrasound. You want to biopsy the spleen. You're going to biopsy liver for staging purposes as well, regardless of what the liver looks like. Concurrent surgical procedures we already talked about. And then postoperative care. VetGuardian takes care of a lot of this stuff, but don't forget PCV checks and pain management with these dogs. Walking is interesting because it ties into what I was talking about before with risking patient collapse. These are older dogs that have cardiovascular compromise, and so you want them to walk outside to hopefully urinate and defecate, but you got to be careful. So I frequently will have the staff gurney the dog outside, put them on the ground, let them do their thing, put them back on the gurney, and then gurney them back to ICU. That way they're only walking for the time that they need to urinate and defecate, and we're not stressing them beyond that. Any questions folks have? This is all my contact information. Feel free. Thank you again to Zomedica for this talk. Hopefully you found it clinically useful, and I'm happy to take any questions, concerns, comments that you might have. Thank you.
All right. Thanks so much, Dr. Shadi. We'll give everyone a few minutes to type your questions in the Q&A box. I already see a few that have come through. While we do that, I will remind everybody that your CE certificate will be coming to you within the next few days, so look for that. Also, check your spam and junk folder just in case you don't see it, but it should be within the next few days. Dr. Shadi, let's jump right in here. First question, do you have any recommendations on taking a biopsy of the liver on how to?
Yeah, so it really depends on what part of the liver you're trying to biopsy. So, for example, let's say there's a lesion in the central parenchyma of the liver. Using like a dermal punch biopsy is phenomenal for that. And with a dermal punch biopsy, using your standard way that you would for the skin. However, you want to make sure that you have ideally gel foam available, and it's really great if you have gel foam that you can cut into like a cylinder type shape, or it's got a cube shape to it or whatever that you can plug into that dermal punch biopsy. So that's a nice way of doing that. Otherwise, if you're trying to biopsy more of the peripheral portions of the liver, like the edges of the liver, or where it's a bit more where it comes more to a point, more of a process, then if you have good cautery, I've done it where I've used cautery to slowly electrocoagulate the liver biopsy or the site. Otherwise, the guillotine method is what a lot of people use. And you can look up any textbook that'll show you, or probably YouTube videos will show you. But basically, the guillotine method is placing a ligature around the liver lobe and tying it, obviously securing it as tight as you can. And then from there, you can either cut the portion of the liver in front of the ligature, right, not behind it. In front of it, the ligature is going to stay in the patient. And you can, when you cut the liver, you can use either sharp dissection if you want, or electrocautery across it. I've even used ligature to collect liver biopsies. If you have the luxury of that tool, it's phenomenal. But those are the ways that I typically will perform a liver biopsy. I don't have any rules as far as how big of a liver biopsy to collect. The pathologists always want more tissue, and so you want to be somewhat proactive with collecting the biopsy, but you don't want to essentially perform like a liver lobectomy. So you have to have some level of experience there with that part of it. Typically, the right lateral liver lobe is the easiest to access, assuming there's no other lesions on the liver. The right lateral liver lobe is one I usually try to go for.
Okay. Next question. What suture type do you recommend for the splenectomy and for the liver biopsies?
For splenectomy, it depends on the size of the vasculature and the size of the patient, because a lot of these are going to be large breed dogs. I'm typically at least using probably 0 PDS for the main splenic artery and vein, and then for the other pedicles, either 0 or 2.0 PDS. I don't think I'd go less than 2.0 PDS for your standard large breed dog that's affected by this. But in the rare cases that I've done where I've removed the spleen in smaller breed dogs, then you can probably 2.0 PDS is good. Maybe 3.0, but I'm probably sticking with 2.0 PDS, especially for the main splenic artery and vein. Obviously, the benefit of using vascular hemoclips, ligature, is that it's more efficient than performing suture ligation. But those are the sizes that I'd usually recommend for that. And again, you're not trying to go for margins. You want to stay right at the splenic edge and removing the spleen. You don't need to get centimeters of margins of vascular pedicles with splenectomy. As far as the liver goes, typically 2.0 PDS is what I'm going to use for the liver, and whatever technique you want to use, like I mentioned, you can use for that. I actually will add to the liver comment as well. It may help to crush the liver lobe before placing your ligature over it. If you can crush the liver lobe, you're essentially skeletonizing it, meaning you're taking away the parenchyma, or at least making it more friable, and only the vascular supply will remain. And that when you place your ligature, you have a higher chance of collecting all those blood vessels in that liver lobe. So that's a kind of a cool technique that I don't know if you'll be able to find that in any literature. I've learned over time to do that. But anyway, hopefully that answers your question regarding the suture size. As far as suture type, PDS is what I'm typically using for these dogs.
Okay, next question. If the pathologist reports a benign mass, is that considered 100% reliable?
Yeah, so just like any other diagnostic, whether you're talking about a machine or a human, there's always a chance of error. And if you have a splenic biopsy that comes back as benign, then when you report it to the pet owner, you warn them there's always a chance this could be wrong. And so it may not hurt to perform 3-view chest x-rays and abdominal ultrasound in the next month or two postoperatively to look for any evidence of spread, since we know that hemangiosarcoma will typically spread within 1 to 3 months, somewhere around there. Or if you're really skeptical of the diagnosis, you can ask for a reread. have the pathologist go back to the sample, cut in all wet tissues, and ask for a reread on the biopsy if you truly don't believe it. At the end of the day, it is very difficult. It can be very difficult because it's a vascular cancer, and you're submitting a large organ, and the pathologist isn't looking at every single slice of that organ, right? They're going to pick and choose and then make slides off that. So you're really getting a small representation of the entire spleen, which means you're prone to missing it, prone to errors. So if you do doubt it, then have them do a reread on it, cut into all wet tissues, meaning they go back to the original spleen and remove new samples. Or if you believe it, but you want to make sure the client understands, warn them it's not 100% accurate. It is a human being reading it, and maybe we should do a MET check and abdominal ultrasound every month, the next 3 months, or something like that. However you want to do it. There's no rules on this. Maybe with the advent of AI, being able to read out cytology, maybe that'll increase the accuracy rate in comparison to human readouts of biopsy samples. We'll see, but I have no experience with that, or even know if that's even an applicable technique. But that'd be cool to see if in the future that can help minimize inaccuracies.
Okay. Next question: would cryoembolization be recommended in some cases?
I have no experience with those techniques. From my experience, from reading the literature on techniques like that, they are typically performed by either an internal medicine doctor or an interventional radiologist. So unfortunately, I don't know the answer to that one. However, when I've read studies for such procedures, boy, they sound impressive. It's very, very cool. But I don't know. I don't know the details of it, unfortunately, and how well it would benefit. I will imagine, if I had to guess an answer, if I was forced to answer the question, I'd say probably not. If you're looking at an active hemoabdomen, you need a treatment option right then and there to stop the bleeding. And even if you're not looking at a hemoabdomen, you need to remove the entire spleen. I mean, because the chance of it being cancer are pretty high. So I'm doubtful if that would help, but I don't want to speak out of turn with it. I don't really know with regards to that.
Okay. We've got a few more minutes, just a couple minutes left for any additional questions. So we'll see if any more of those come through. Dr. Shoddy, Dr. Rubin, and Dr. Morehouse also say hello.
Oh, hey, hello there. Hope things are going well. Thanks for attending.
Yeah, we've got a little bit of time left while we have Dr. Shoddy with us.
Thank you for all the questions. If you're a general practitioner, watching, listening to this, and you want to dabble in splenectomy, I would say the ideal client is one who can't afford specialty care, or they can't access specialty care for geographic reasons or whatever, and they're understanding that you're not as experienced with it, but you're happy to give it a try. Those are great cases to I don't want to say practice from, but that's where you can get your initial experience. The other suggestion that I have for folks who want to dabble in this is cadavers. If you have access to cadavers, either you purchase cadavers or you euthanize a pet, and you get the client permission to perform a splenectomy on the cadaver. Great way to practice. So keep those things in mind. I don't want general practitioners to be scared of this procedure. It is a viable option, especially these days when we talk so much about spectrum of care. Feel free to bring it up to pet owners, and as long as they understand all the things, then feel free to have at it. And I'm accessible to folks. If you have any questions, intra-op, post-op, feel free to reach out. But as a GP, I would say this is one procedure you could perform, understanding all of this stuff, and that the client understands all the things. And then post-operative care to try and maximize success is imperative for these cases.
Okay, good to know. All right. Well, Dr. Shoddy, I definitely want to be respectful of your time and everybody's time today who joined us. I don't see any additional questions that have come through. So with that, we'll go ahead and wrap it up. And again, I want to thank everybody for joining us. Dr. Shoddy, it's always great to see you. I hope to see you somewhere live at a conference soon. And with that, everyone, have a great rest of your week. We'll see you on the next webinar.
Thank you so much.
Bye, everyone.